care in patients presenting for genetic disorders. Major area of interest of mine in the past 5 decades have been Prader-Willi syndrome. Began in the early 80s, and I've continued studying Prader-Willi syndrome since that time. And I've been a clinical geneticist, been involved with several genetic conditions, but Prader-Willi syndrome is primarily my major focus. I'm interested in genetics, obesity, and Prader-Willi is a clear example of that. Genetics of autism, congenital anomalies, and dysmorphic features. So all the above regarding genetic findings we see in our clinic setting. It's a condition that's been reported since 1956. More investigative studies began in the 1980s when the deletion of chromosome 15 was first identified in Prader-Willi syndrome. Prader-Willi syndrome is considered the most common genetic cause of pediatric obesity. It occurs about 1 in every 20,000 live births. There are approximately 200 babies born per year in the United States with Prader-Willi syndrome, and probably around 7,000 worldwide. We recognize over 400,000 individuals with Prader-Willi syndrome in the world. It was the first example of genomic imprinting described in the late 1980s. Genomic imprinting is a concept whereby we recognize that the gene expression patterns received on chromosomes from the mother act differently than the expression pattern received on genes from the father. So the genes are imprinted. They are impacted by the parent of origin, whether they come from the mother or the father. Prader-Willi syndrome is the first example of these errors of genomic imprinting, as we find out that the chromosome 15 Q11 Q13 deletion, which is seen in about 70% of patients with Prader-Willi syndrome, the deletion is contributed by the father. Chromosome 15 from the father undergoes this deletion, leading to the findings we recognize as Prader-Willi syndrome. We see this in about 70% of cases. About 25% of cases have what is referred to as maternal disomy 15, which indicates that both chromosome 15s come from the mother. This is due to an error in meiosis when the egg is being produced. And that occurs about 25% of the time, while the remaining 5% or so is due to imprinting center defects. Imprinting center is an area on chromosome 15 that controls the activity of those genes that act differently when they're inherited from the mother or the father. It's of interest because those individuals have this imprinting center defect. They can have a certain type, therefore a small deletion of the imprinting center defect, which could indicate that there could be a 50% chance that the parents could have another child with Prader-Willi syndrome. Usually Prader-Willi syndrome is not inherited, it's sporadic, but there is a small percentage where it could occur 50% of the time. So it's important to identify the genetic causes because it does impact genetic counseling for the family members. Now, what are the features of the syndrome? The major features we see at birth is severe hypotonia. These babies are born very floppy, so much so they have the image of a rag doll. They're very floppy individuals, and they have really no interest in sucking, feeding, and it's very severe, it's thought, when they're born because they look like that they have a major problem. They may have a major infection, may have a major brain abnormality, may have a major metabolic problem, so they're undertaken with various types of studies to identify why they're not, have no interest in, no suck, no movement, decreased muscle mass, muscle strength, and energy. We find out that someone eventually considers the possibility of a genetic condition, and they'll order genetic testing, and often the genetic test will identify the chromosome 15 defect, which causes Prader-Willi syndrome. So sometimes a diagnosis is not identified at birth, it's identified after testing has been obtained. We've ruled out brain problems, we ruled out infections, we ruled out organ involvement, because generally Prader-Willi individuals do not have congenital anomalies. They have no abnormalities of the heart or lungs or kidneys. The problems that we see is related to brain function, neurological. So that's kind of what we see. We see an infant that looks physically very weak, have no interest in eating, failure to thrive, no suck, and they have to be tube fed, either tube in their stomach or tube through their nose because they don't suck. And failure to thrive is a major problem. Now, this is of interest because these individuals will begin to have an interest in eating many months into the process. So they have to be tube fed or force fed until 2-3 years of age. Then they begin to develop an appetite. And when they develop an
Sincere
appetite,
thanks
they don't
to
stop
the
eating.
Alliance,
It
to
develops
Sourcell,
hyperphagia.
and to
It's
all
an
of
interest
you
because
who
they have
are
no
on
interest in
the
eating,
call, who've been
but then when
participating
the
in the
appetite
debate,
is
in the
turned on, it's
advocacy,
not
those of
turned
you
off.
who are
They'll eat
in
anything in
Brazil
sight,
as
basically,
well.
and they'll eat
I have no
until the
doubt
food is
that
gone,
what we have seen from
they fall
ICN over the
asleep,
last 2 or
or
3
stomach
years,
rupture
you have
occurs.
been
Stomach
really
rupture is a
effective. You've
cause of
done a
death in these
fabulous
individuals,
job
so they
in
have to be
terms of
very
raising
controlled in their
the
eating environment,
visibility
or
of
it can cause life-threatening
nursing and the
situations.
impacts and implications
So
and
hyperphagia
consequences
onset is around 6 to
for
7 years of
health
age.
more
And these
generally. And
individuals
I
will develop this appetite,
genuinely
but they
want to
also
thank
are
each and
small in
every
size.
one of you for
They can
that.
have
Give a shout out to my
hormone problems,
colleague
growth hormone, other
Gilligan,
hormone
who you will hear
deficiencies,
from later on this call,
and they have a
who has been
developmental delay,
central
poor
to
muscle tone
helping that happen
development,
from ICN
and
and working
they
with
can have
all of you.
underdevelopment of sex organs,
Listen, I think we all know that we
hypogonadism,
are at a
hypogenital.
moment
When
of
appetite starts,
great
then
change,
it's a real problem when it comes
uncertainty,
to medical
and
management of these
risk
individuals.
for
So
our
it's a
world
very
as
rare
well.
condition, but it
We
has
seem to be
unique
moving
features
away from
related to the failure
an
to thrive
established
stage
order,
early
a
on, then
rule-based
hyperphagia and
order, of a
obesity that results
multilateral
in early childhood.
approach
And the
to
obesity
one where
can
the
be life-threatening
strongest
if
and the
not externally
mightiest
controlled.
are dominating, and issues which are of
Well,
concern
when they're first
not just
born,
to us and our
there may be a
professional elite,
history.
to
The
the
mother
planet in
who
climate
may have
change.
had previous children
We
will say, well, I didn't
see
really feel
receiving
the
significantly
kicking, the
less
fetal activity
attention,
before birth. So there may be
noticeably
some
being
indicators that the baby may
relegated
be
down
struggling
the
by the time of
world
birth. So
priority
once
order
they
of things
arrive,
to
they have to be
issues to
evaluated and so forth.
address. I
But
saw
we
that
know
very
that when
directly
we see these
myself at
individuals,
Davos
that
this year.
requires
I was
lots of
there for a short
interventions.
period
We know they have
of
to be
time,
monitored very closely.
engaging in
Speech
some of
therapy is
the West
involved.
Side
We know
events
feeding
and
problems
debate
is
on
present.
personal
Swallowing
and health
difficulties
issues,
may be
issues
present.
as you'd
So
expect.
we know
But
they
there was
require a
very
team
little that I
effort to
saw on the
undertake
agenda
various
as it
studies to
related
make sure
to
that
health
they're
and
growing
nothing
normally. So
in
when they're
relation to
genetically confirmed, we
climate
know that
to
growth
climate
hormone is
change.
approved. It's been approved since the year
For
2000 for
understandable,
treatment
for
to treat
obvious
the short
reasons, I
stature that's
clearly
present,
agree
and it
with
also help
those.
growing the
But
muscle
let me
mass and muscle
not
strength. So
be
growth
too
hormone is
negative
recommended for
about that,
treatment
though, because
once they're
there
genetically
were issues
confirmed.
which were featured
Dietitians are present
significantly
throughout their life. Obviously, they have
that
to record the caloric
not just the
intake, make
politicians
sure there are
but the
enough
leaders of
calories, but not
industry
too
and
many calories.
companies
That's
who
throughout
were
life.
attending
We know they can have
Davos
feeding problems,
wanted to talk
so we
about
know
in
endocrinologists are
relation to
involved for the
technology,
hormone treatment.
issues
We have to
around
monitor the feeding
equity,
process, and
and of
GI
course
issues might be
always
present. Mental
economic
health
impacts,
experts
economic benefits. And
should be there because
it
they can have
struck me
behavior
very
problems.
much that
They can have
through
self-injury,
those other
mild
issues, a very
learning
clear
issues, but we know they can
links
have
up,
abnormal
relationships
behavior,
that we
aggression,
must and need
outbursts,
to join the
compulsions.
dots to
And
in
sometimes we
relation to
realize some of these
the
behavior
role, the
findings and psychiatric
contribution
issues
of
might correlate with the
nursing
genetic
profession and the
subtypes.
impacts on health
Those
as
that
well. So
have the maternal
it's a
disomy, for
difficult
example, they're
time, it's
more
a
at risk of having
challenging and it's an
autism
uncertain
in
time,
childhood
but there
and
are, I
greater
think,
risk of having
approaches
psychosis
and
in adulthood.
strategies that
Those with
we
a
should be
deletion
beginning
usually
to
are more
looking at
severely
and that we
involved
can
with the clinical
leverage
features
and that we can
we
use
described.
as
So
well.
it's important
And
to identify
one of the
early
most
on,
powerful
confirm the
ways that
diagnosis,
I see
confirm the genetic
time and time
subtype,
and time
because that will
again
impact
to make a
on
real
the
impact in
collection of
terms of
medical
an
experts that we
intervention or
needed
raising an
to
issue
treat
or
this
joining
individual
in
from
a debate or
childhood
even offering
through
a
adulthood.
criticism is when we bring the real life
Well, it
examples
starts
of
from the
the
beginning. It bends,
impacts
you
that
know, when
we
we
as
think
nurses
30 years
see
ago, the average
of
age of
climate
diagnosis was
change
10 years
on
of age.
people's
Now, because of better
health.
awareness and better genetic
Nurses can
technology, because
speak with
often the genetic
huge
testing is
authority,
done,
power, and
not
authenticity
ordering for Prader-Willi
about what
syndrome,
they
but
see
because
happens to
genetic testing is
people that
ordered
they
and the
care
diagnosis
for.
was
Obviously,
come
that's
up through
often,
the testing,
very
but it wasn't
pronounced and very
proposed to look
obvious
for
when you're
Prader-Willi
talking
syndrome. It
about
just was a
a
result of the
disaster, a
genetic testing.
climate-induced
So we
disaster.
know they
Someone's
have to
lost
be
their home,
identified
they've
early
suffered
on, genetically
traumatic
confirmed, and that will make
injuries,
an
there are mental
impact
health
in how many
implications, there are
medical specialties,
migration of
what the
populations, and
prognosis and
all
natural
of the
history
health
might be
issues
related
that flow from
to the
that
syndrome.
as
So
well.
multiple experts are
But
involved from the
outside of
beginning,
the
depending on how
disasters you're
early they were
talking about, nurses are
diagnosed.
also
We
seeing
know that developmental
people who
involvement is required
are
throughout
living with
development,
chronic
throughout
conditions but
childhood.
struggling because of
Endocrinologists,
changes in
geneticists,
weather
kind of
and
quarterback the team to help
extreme
the other
events and
specialists
not
be
wanting to
aware
go
of the
outside and maybe
milestones, what
not
should be looking for at
socializing
different
habits
ages
change
regarding the syndrome.
their
Mental health experts,
issues around food,
psychologists,
as well
GI
as
doctors,
exercise
We know they have sleep problems, so sleep experts are often required. We know they're prone to having scoliosis with or without growth hormone. So orthopedic consults are involved. So really, it's one of the conditions where many neurologists, many experts will probably be needed sometime during this child and young adult care to be on the lookout for certain problems that can result in the natural history of the syndrome. So it's a multidisciplinary approach that's needed from as soon as diagnosis is made.
And I see that in the work that you have all been doing.
It's a very
I think
active area of
precious is something
research.
that
There
is
have
not
been
allowed to be trusted
over a dozen
because I
clinical
think we should
trials in
never lose
Prader-Willi
sight of
syndrome in the
that.
past 10
One of the other
years
great
plus. The
challenges that we
drug that's
face in
been
our
approved
career is
last
a
year
loss in
was Vicad,
science
which
and
is
spread of
to treat the
misinformation
hyperphagia, which
as
is a
well.
number one
We
problem because
see
hyperphagia
corporate
itself can lead
takeovers and
to
capture
severe
some of the
comorbidities and
big
death
global
related to
events like
overeating
COP as
episodes
well. Well,
we
we're a 30
described.
million
The
strong
median age
convention
of
with
death
the
is
most
thought to be 30
trusted
years of
voices, and
age,
I
but we
think that
think
we have a
those are
great
treated with
opportunity
growth hormone
for nursing to
might have a
capture as
longer
well of these
expectancy
debates that you will be
because
at
they're
the forefront
stronger,
of. And
they
never
can be
forget
more
that the
active,
trust
physically
that
more active and
patients and the
more
public
aware
have
of their
having us
situation. So it
come
might
from
normalize them to a
the
certain degree,
ethics
but
of
they
which
still
our
will
practice
have
is
an
based.
onset of
And
death
I see
earlier.
it as
It's
code of ethics that speaks
often
directly
related to the
to
excess
issues around
eating
climate
issues.
justice,
So
climate
we
change, the
try to
impacts
diagnose
of
early.
health
We try
as
to
well. So as
monitor them
challenging
closely and
as
be aware of certain
this moment
milestones in
is,
life
the
cycles that are present and get the
of
specialists
work that we're
involved to
doing
help
together,
be on the
your
lookout for
work,
those different
your
issues that come
advocacy,
along, whether it's
your
endocrine, whether
leadership
it's GI related,
has never been
psychiatric
more
problems,
important. But I
or
believe, for all the reasons I've
whatever
said,
happens with
that
regards to
you
this
can, you
patient.
are, and you
So we try to avoid the
can
obesity because,
continue
as
to
we
make a
know,
real impact and
obesity can lead
shift
to
in
comorbidities,
decisions
heart
that
problems,
we
etc.,
make and
diabetes
the
and things
decisions
like
that are being
that. So they have
taken
to be
and the choices that are
monitored
being
very
made as
closely
well.
and
I look
very
very
close
much
with
forward
regards
to
to food
hearing all of
intake
your
because food can be
contributions
their
further in
enemy.
this webinar.
As we
Thank you
mentioned,
very
they
much.
can,
Back
if they
to you,
get
Grace.
access to food, they'll continue to eat
Thank
until the food
you
is gone or their
so
stomach
much.
can
And
rupture,
now I
which
would
is
like to
life-threatening.
call in and welcome a powerhouse 90
I think
technical
we need to
international
have as
affairs
many
advisor
specialists
for the
involved
Brazilian
because they'll
Ministry
be
of
needed
Health
sometime or
and the
other because
Honorable
we have to
Regent
develop a
Benito
plan depending how
Nariz.
early they're diagnosed. They're diagnosed at 3 months of age. We have a different
Thank you
plan
so
than if they're
much for having
diagnosed at
me.
3 years
It
of
has been
age.
great to
So
listen to
earlier
your
diagnosis, be
perspectives.
aware of the
I'm going to share a
situation, and
presentation on
genetic
the very
testing is key because there's so many
influential
different
contextualize it.
genetic subtypes
Just
can
bear with
impact
me
on
for
the
a second.
severity and the outcome of the
Okay.
condition as well as the genetic counseling. As we mentioned, there's a certain genetic subtype that could be a
So
50% risk
the
for this to
Delegate
occur
Health
for other
Action Plan
children.
was
So it has an
president's
important
proposal
aspect from
for
the
the
family
action
counseling
agenda
standpoint,
during
genetic
COP. The
counseling, as
action
well
agenda happens
as
outside of the
healthcare maintenance and
negotiations.
surveillance
It's
for
for
individuals,
actors that are
depending how
willing
early
to
they're diagnosed. We
implement
try to diagnose early, confirm the
initiatives
genetic
that could help
subtype,
advance on
be
climate
aware
action.
of health concerns that
And
can
in this
arise
sense,
depending on a
last year
specific
the
genetic subtype, whether it's
agenda had
deletion,
five
maternal disomy,
pillars.
imprinting
One
defect.
of it was
But
human
then
resource
we try to
development,
get the
and one
team
of
in
its main
place
objectives was
from
promoting resilient life
occupational
systems.
therapy, speech
Under this
therapy, physical
mandate,
therapy, developmental
here the
assessments
Ministry of Health in
throughout their early
Brazil has
childhood, make sure
developed
to
the
get enough
Delegate
calories
Health
on
Action
board.
Plan
We maximize
as
their
a
physical
proposal for
activities
countries
and
to
try to give
endorse
them
under a
as much
voluntary
strength as they can.
framework
Growth hormone
with
is
the
needed.
goal
And
to
monitor and be
advance on
aware of
health
the fact that
surveillance
they can
technology
develop scoliosis, severe
innovation aimed
scoliosis
to
in
strengthen
early
multi-sectoral
teenage years.
policies
So we have to be
to
on the lookout for
deliver
those
a
kind of issues
more
that come up,
resilient health
sleep
systems.
problems, ENT
So
issues,
in this
endocrine problems,
sense,
and
the
multiple
plan
problems can occur
considers the
as
diverse
we
needs and
described,
national
requiring
contexts of
hormone
health
replacement.
systems
So
around the
endocrine is a
world,
key player from very
and that
on,
we
and
need to
genetics
have
involved because
cross-sectoral
we're trying to
collaboration
understand the
to
natural
accelerate
history.
both on mitigation
Studies
and
have shown that
adaptation efforts
a
to
pediatrician
generate
throughout their
healthcare
career may only see
benefits.
three
So
Prader-Willi
we
patients
understand
throughout
that
their career.
tackling
Even though
the
it's a
effects of
pediatric
climate
onset
change
disorder,
involves
pediatricians don't
actors
have the
not
experience
only
because
from
they may only see one once every
the
10 years.
government, but
Genetics is
from
important because we see
the
these patients all the
medical
time, and
profession. So
therefore
for
we're kind of the
nurses as
quarterback of the
well, we
team.
want to have
Will
civil
be consulted
society.
from
We want to
endocrine,
have
surgery,
international
occupational health,
organizations,
whatever,
philanthropies, multilateral
education, whatever it
development,
is, we
all working
are
together to
needed to
develop
help
and
organize
implement
the treatment
adaptation
protocol and plan.
policies that
That
will
can
help
vary from
the
person to
health
person,
sector
but again, the
adapt
major
to
problem
climate
is a failure to
change.
thrive during infancy,
So the plan
hyperphagia and
is
obesity
structured around
during early
three
childhood,
action
and other things
lines.
that come along. We
The
talked
first is
about the
surveillance and
endocrine
monitoring,
problems,
which includes
hypogonadism, the
improving
behavior issues,
climate-informed health
the mild
surveillance,
learning issues
because we need
that
to
can
be
come along with this disorder,
working on a
and other
multi-sectoral
complications,
way
GI related
that
and
includes
orthopedics, depending on what
data
happens.
that
So it's something we've tried to diagnose early, identify genetic subtype, because that might help us open up what chapter of the book we need to read, depending on the genetic findings that are present and what to be looking out for. We try to be on the lookout for these issues. As with anything, you find the problem early, it's easier to treat than trying to treat it as it progresses through life. I think we have to realize that even though it has one title, there are 7 different genetic subtypes.
Action line 3.
And the
Focusing on
subtypes we're beginning
innovation,
to
production, and
realize can
digital health.
impact on the
So in section
longevity,
lines
can impact on the
2,
natural history,
improve
and obviously
access
can
to
impact on the
technologies
genetic
that can
counseling.
help
So
the
I
health
think it's
sector
important
adapt,
to identify
looking
that
to
not
strengthening
a
its
genetic type, but
resilience
have
and
to further
infrastructure so
characterize
that
there
when we have
are
extreme weather
4
events,
types of deletions, for
healthcare
example.
healthcare
Even though we
services
call
can
it a deletion,
continue
there's 4 kinds.
uninterrupted.
And
It
then what we're
also
beginning to
means
realize through research that the
strengthening
different genetic
stockpiles
deletions might
and
have different
enhancing the
outcomes. We need to be
resilience of
looking
health supply
more
chains.
closely for different areas than we would
And
if
the
we didn't know that
cross-cutting
information.
principles of this
So I
plan
think
are
better awareness,
enhancing health
the problems
equity
that we
and
see
climate
that not
justice,
only
which
relate to
means
Prader-Willi
that
syndrome, other rare diseases,
adaptation
is
needs to
when we
consider
study
the
when we study
differences
a
that can
condition
be
in clinical trials, may have 100
socioeconomical,
patients.
ethnic,
Other clinical trials,
racial,
other
in
conditions, they may have
when
10,000
the
patients.
adaptation
So we don't
policies are
understand the natural
developed
history of rare
so that
diseases.
they
We
can
don't
be
understand the
effective,
rareness of rare diseases.
considering the
So
different
we're
contexts,
not aware
and
of the
also
things that occur
leadership and
1 to
governance
2%
and
of the
social
time because we only have
participation,
100
which
patients
means
we're
that when
aware
we
of.
are developing
Now, if you're
health
1,000
policies,
patients,
we
you're
need
aware
to
of those
have the
1 or 2%
participation of different
defects that can
sectors of
happen. But
society
with rare
so
diseases,
that
we don't know the rare
the
outcomes. And with the
outcomes
rare
can be
outcomes, we know are
implemented by
becoming a real
different
issue for
actors,
some
but that we
patients
also
that we didn't know
have them
existed. For example, blood clots
participating
might
at
might
every
be an issue.
stage
We
of
didn't
policy
realize that until
formulation.
studies
So
indicating
for
that blood
everything
clots is
that
the
we
4th
are
most common
proposing
cause
on
of
this plan,
death in Prader-Willi
we need to
syndrome,
have this
and it
health
was brought
equity
up because of one
lenses
of
in
the clinical
mind.
trials. So we don't know if it's an
Regarding
outcome
the
of the
relevant measures
condition or an
that could
outcome
be
of the treatment, but we know it's something that we do see in the
implemented
population.
into
So we
nurses'
need to have a better
practices or
understanding of the
that we
natural
can
history
have
of these
more
conditions,
nurse engagement,
know
we
what
have
happens long
highlighted
term. There need to be
the
more studies done in
measure to
adulthood,
protect and promote
and we need
workers'
to
health in
realize
context
that
of
rare
climate
diseases
change,
have these natural histories,
which includes
lack of information, natural
having
history. We
evidence-based
also know
regulations
it's
and
very
policy
difficult to treat rare
interventions
diseases because
that
it costs
consider the
money
impact of climate change
and we don't have the funds for
the
these
work
rare diseases.
environment.
We
We
know
know,
we don't have the
and
natural
as
history to
was
know how the
mentioned
drug
here
may or may
today,
not work
that
on the
nurses are
condition
on the
because the
front
biology of
line
the condition
of
is
climate
different, unique
emergencies.
to that
So
disorder.
this
And we know
has
that
indirect and
some of these
indirect
resources
toll
aren't
on the
available
physical and mental
worldwide.
health.
We know some
And
patients
when
haven't been thoroughly genetically
policymakers
tested, so we don't
are
know the genetic subtypes. So it's very
developing
difficult to
adaptation
treat and monitor
policies, it
rare
also
diseases
needs
because
to
there's so
have
many different
interventions
variations,
that
even in
will
rare diseases,
provide
that we don't understand yet.
psychological care for the healthcare workers that are attending
We
to
have
the
to talk
public
with
every
them
day.
because they
We
will
also are
obviously,
proposing
with the
surveillance for
marvels
workers' health,
of the internet,
which
right? They'll read
means
about things,
having
and some
local
things
and
they read,
regional
as we all
workers'
have to be
health
aware
teams.
of, some
So
things are
it's
very
more on the
accurate,
angle
internet,
of
some things are
occupational
not.
health
So we
to
got to figure
cover
out
and
how
provide
much they've
for
read and what they've
formal
learned,
and
or that
informal
they have to
workers.
relearn. How
And
much
we
is
also
factual
propose
information? Because what we do find out
multi-sectoral
that it's
engagement and
not
coordination among
uncommon
public
that the
sector
diagnosis
entities to have
is made by the
adaptation
parents.
policies that
The child's in
implement
NICU, not
safety
feeding, has a
standards.
G2 place, and the
And
doctor
on
goes,
the
well, we
angle
don't
of
really know what's going
strengthening the
on.
health
We've done everything,
workforce
we know
to
what to
address
do.
the
So
challenges of
doctors are
climate
looking at this, the
change,
healthcare
we
providers,
proposed
the
having
parents are doing this
technical
24/7, right?
capacity building for
So
the
they're on the
health
internet, they're
workforce
searching.
to
And
address these
they're often
impacts,
are the ones that come in with information
regularly
about,
updated
I
training
read about this
programs, and these can
Prader-Willi
include
syndrome,
environmental
and then the
health and
nurses are,
climate change training for
oh,
nurses.
yes, maybe, okay. And they're
We
often are the
also
ones that stimulate the
propose
genetic
to
testing.
integrate environmental and climate change
So the
related
parents are the
content
ones that
into
provide
health
this. Now there's more
education to
awareness
better
all the time
prepare
in the
the
medical community.
workforce
That's a rare
to
condition.
deal
There's
with
only
these
200 babies born
challenges.
per year
This
in
can
the U.S. per
include
year.
knowledge
So it's
exchange
a
through
rare
peer
disorder.
learning
So
and
again,
mentorship,
a pediatrician, 3 patients in their
interdisciplinary
career. So
programs that
the
include indigenous and
non-geneticist
traditional
physicians are
knowledge,
not really
because
aware of this
as
disorder. Some
the
are,
healthcare
but most have
workforce
to
is
have some
working
instructions to go
along
with this.
different
So I think we
countries,
have to be
regions,
careful what we
and
learn,
there are communities that
what
have
people are aware of
specific
this
needs.
condition, because what we
We
read
understand
about
that
from 20
health
years ago, because
education
of earlier
should
diagnosis and
include
treatment
this
and more
context
options,
to
growth
prepare the
hormone,
professionals
Vicad, which is a drug that's been approved for
for
hyperphagia
your
recently,
perusal.
we
These are
may have a
the
better outcome
countries
in the
that are
future is
currently
more
endorsing the
hopeful than
Building
it
Health
would have been
Action
20
Plan
years
right
ago.
now. But our more countries to support this plan are ongoing, and we hope that the association association can engage with the government of these countries because they now have a commitment to promote the health sector adaptation and to consider the healthcare workforce as one of the main agents that can help with the implementation, but that also need to be protected during this process. And here are the outcomes of the health day. So everyone that was present on that day, and a little bit of context for you because I know my time is ending. So the plan is the first international climate adaptation plan dedicated to health. We had a total of endorsements, and there was the announcement of the Climate and Health Funders Coalition to implement $300 million to advance on the implementation of the Belém Health Action Plan. And we are very happy to have actors like you engaging with the content of the plan because you are very needed to advance on implementation and to further the adaptation of the health sector. Thank you for hearing me today.
Thank you so much, Nani. What an amazing effort. And thank you so much for your continued work that you're doing today on that. Next, I would like to call in Milena Sergeyeva, Networks and Engagement Lead from the Global Climate and Health Alliance, who helped to coordinate and keep all of us up to date on the ground in Belém. Welcome.
Thank you so much. I'm just going to share my screen. That is hopefully visible. My name is Milena Sergeyeva. Thanks for the warm welcome. I'm the Networks and Engagement Lead at the Global Climate and Health Alliance. The Global Climate and Health Alliance works at the forefront of a growing global movement of health professionals and health and development organizations dedicated to promoting a healthy, equitable, and sustainable future for all. We address the climate crisis through evidence-based advocacy, policy, movement building, research, and strategic communications. We have over 250 organizational members from every region, and they're reaching over 125 countries. The Alliance co-chairs the WHO Civil Society Working Group on Climate and Health and collaborates with organizations and agencies around the world to ensure that people's health is protected in the climate crisis in national, regional, and international decision making.
Milena, sorry to interrupt. If you're sharing slides, we can't see them. If people see? Oh, now we can. I'm sorry. Can people see those? Yes, they're up. Thank you.
Oh,
I can
thank you so
see
much.
a slide. I'm not sure if you've advanced yet.
There,
that's working.
Now?
Yeah.
Great. All right, so I'll tell you a bit of history of the health movement at climate conferences. Health has been getting more and more attention within the climate conferences thanks to the joint efforts of the Health Civil Society and the World Health Organization. Over the years, GCHA members such as International Council of Nurses and the Alliance of Nurses for Healthy Environments have taken pivotal actions together using the trusted voices of the health community to call for health protective climate action, and we are forever grateful for your commitment and your engagement all the way through. GCHA itself was created in 2011 at the COP in South Africa, and since then it first organized climate and health summits outside of the negotiation space and sent small early delegations at COPs. Since at the COP21 in Paris, where the Paris Agreement was adopted, there was a big health declaration representing 13 million of health professionals, and it called for the right to health to be embedded in the Paris Agreement, which it was. And another milestone is the first ever special report that was delivered by the World Health Organization to the COP presidency, and it was commissioned by Fiji, the presidency of Fiji. COP26 then saw great engagement from the health community and the ramp-up of activities on health with the first health pavilion, which hosted by the World Health Organization and the Wellcome Trust, which since then has had full 2 weeks of events on climate and health at Blue Zones. The WHO Civil Society Working Group and GCHA organized regional consultations before COP this year. And it provided inputs for the new special report on climate and health, which was delivered to the COP presidency. And health professionals arrived to COP26 with a healthy climate prescription letter representing 46 million healthcare workers around the world. The UK COP presidency developed a whole program on health and climate, which included the launch of the Alliance for Transformative Action on Climate and Health. In Egypt, the final decision included the right to clean, healthy, and sustainable environment, and health was established as a cross-cutting theme in the global goal on adaptation, which measures how we are progressing to adapt to this climate crisis happening. This slide looks a little full because at COP28 we saw a record number of health professionals attending, including 50 ministers of health. We had the first health day and the ministerial declaration on climate and health, which was signed by health and environment ministers. It mentions intersectoral climate action for health. And at COP28, also guiding principles for health and climate financing were adopted. A big win for climate and health is from this COP was the inclusion of transitioning away from fossil fuels in energy systems in the global stocktake, which was the final decision of this COP, which tackles the root cause of the climate crisis and so many other health impacts related with the different activities of the fossil fuel industry. And however, for health to be a real accelerator for climate action and in order to minimize climate impacts, we need to have health considered in a cross-cutting way across all of the negotiation tracks. And this is what we have been doing together with the Health Civil Society for the last few years. GCHA has coordinated a wide civil society policy group that works all through the year to develop the recommendations for negotiations and really follow the developments during the year and adapt the recommendations and also bring them to negotiators and decision makers at different stages of negotiation to reinforce the ambitious climate action with the health arguments. And we have been, we are together increasingly knowledgeable in climate negotiations and becoming experts in advocacy and using this trusted voice. We, at COP30, as many mentioned, we saw the adoption of the Belém Health Action Plan, but also we brought the wider health community recommendations for negotiations, and we saw also effort from Latin America and the Caribbean developing a joint position on climate change and health. And we also had a health march on the streets of Belém, Health and Climate March, which was joined by some nurses I see on this call today. So I won't touch very much on the Belém Health Action Plan. We heard about it. There was a new special report by the World Health Organization, and countries had to deliver their new climate commitments last year. So we saw some countries pledge on new action on black carbon, which is really important for health. In the final decisions of COP30, we saw the human rights to health and to clean, healthy, sustainable environment mentioned in the Mutirão decision, which is in an indigenous language from the Amazon, a common effort. It also, this decision acknowledges the economic and social benefits and opportunities of climate action, including economic growth, job creation, improved energy access and security, and public health. It reaffirms the doubling of adaptation finance by 2025 and calls for efforts to at least triple adaptation finance by 2035. On the global goal on adaptation, which was a decision that was very much awaited, a considerable group of health experts have been working for 2 years on the selection of indicators to measure progress in each country on adaptation. In the end, we saw a different process. The COP30 presidency proposed indicators which were adopted. There are different sets of indicators. So now there is a new process needed so that these indicators are aligned to national policies everywhere around the world. And this program of work will end in Ethiopia at COP32. I will rush through as I don't have much time. In the just transition space, we saw the right to health and the right to a clean, healthy, sustainable environment in both the preambular and operative paragraphs. We saw the inclusion of care, economy, and social protection, and the need for scaling up access to clean cooking, highlighting the main co-benefits of clean cooking in terms of health, gender equality, the environment, and livelihoods. And in the gender negotiation space, there was a gender action plan, a 9-year plan adopted, which looked to increase knowledge in emergent issues like sexual and reproductive health and rights, gender-based violence, and unpaid care work in the context of gender and climate change. I will end by saying that the results are very hard to obtain. We are facing a multifaceted challenge, and often we are very disappointed, but there is thankfully an ever greater interest from health organizations and from each and every one of their members, and a strong commitment and engagement and a resilience, and also the acknowledgement of the importance to work together and care for each other. And we're very thankful for our final efforts this year have been focusing outside the UNFCCC, as we didn't see the expected results of the roadmaps for fossil fuel phase out and halting deforestation. So now the presidency has invited interested stakeholders to provide inputs for these roadmaps, and we're working on them. And there is also this process outside the UNFCCC, the Santa Marta conference, the first one, and we are hoping to engage together with all of you to help shape the transition and include health considerations there. And thank you so much for the attention.
Thank you so much, Milena. GCHA's leadership in this area is so critical for the climate and health community. So thank you for joining us today and for your leadership in this area. I just want to again thank Howard, Nani, Milena for really providing the foundation for this webinar, why we're here for this discussion, and providing a recap of everything that happened the past year. My name is Kara Cook. I'm the Deputy Director with the Alliance of Nurses for Healthy Environments, and I'm going to provide some additional context to this session today, as well as kind of shift us into more of the interactive portion of the event. So as Grace had mentioned in the beginning, Sunciel and Annie partnered, actually launched a year ago at CSW, a CSW event in which we made the announcement that we had this partnership and we were going to be hosting a COP30 series focused specifically on the actions of nurses relating to climate change. So we had, throughout last year, we had a 7-part webinar series which led up to COP30 in Belém. In addition to the webinar series, because one of the goals was to raise awareness and education for nurses about the COP process, as well as the way nurses could engage at COP and beyond. We also wanted to showcase the voices of nurses. And so we have, at the end of the series, we hosted a social media challenge in which we asked nurses to share videos and images of them and provide a brief quote about how they were taking action, whether that be participating in COP or just action within their practice settings. And I wanted to report back on that campaign. It was incredibly successful. We had about reached nearly 8,000 people, and we had about a little over 11,000 in engagement, which is really great for a campaign like this. And we noticed that people were really interested and engaged with the on-the-ground content. So we had nurses who attended COP who took a quick selfie video and shared their experience, and that those posts got a lot of engagement. And I think that just really showcases that people are looking for nurses to lead in these spaces, and nurses are ready to step in those spaces. And I really loved Howard's comments about let's have nursing capture. And I love that nursing and health capture of these processes, because it's so critical that we're elevating the health connection in these conversations. So without further ado, I'm going to move us into our panel presentation, and I'm going to introduce our moderator for the session, who will then introduce our fantastic panel of speakers. So first I will introduce Dr. Gil Adinsky, who is the Senior Policy Advisor at the International Council of Nurses. Dr. Adinsky is a doctorally prepared researcher with expertise in global health workforces, health policy, and health system strengthening. We've worked very closely with Gil, who has been a great partner in our climate change work with ICN, and who was also on the ground at COP. So I will turn it over to Gil to introduce our panel.
Thank you so much, Kara, and thank you so much, Grace, as well, for planning this incredible session. It's such a pleasure to be moderating. As Grace said, I'm a senior policy advisor at the International Council of Nurses, and I've had the pleasure to have climate in my portfolio. Right now, we're also celebrating CSW, and as nurses, we really know those links between climate, health, and gender equity, and how interconnected all of those themes are. And as a women-dominated profession, we know that it will be those female nurses on the front lines of all of the climate disasters and health surges that we'll see as climate change continues to progress. So it's really important to have this advocacy today. I'm really looking forward to sharing our panel today. I'll introduce them, and then I'll give them a brief chance for them to introduce themselves and why climate is an important topic in what they do. So first, we'll have Millie Elia. She is the manager for the Climate and Clean Energy Advocacy at the Alliance for Nurses for Healthy Environments. Aaliyah, do you want to come in first and briefly introduce yourself, and then I'll introduce the next panelist as well?
Yes, thank you so much, Gil. So my name is Milagros Elia. Everyone calls me Millie. As Gil said, I am the program manager of Climate and Clean Energy Advocacy here at ANNI. And my background is as an oncology nurse practitioner. One of the reasons that COP was so meaningful for me was to see that nursing voice really coming up in COP30, offering that health expertise to climate policy decisions. Thank you.
Thanks, Millie. Next, we'll welcome Kat Kruger. She's a registered nurse and nurse practitioner scientist at the University of Michigan with a strong commitment to advancing global health systems resilience and nursing leadership. Kat, you want to come in and introduce yourself as well?
Yeah, thank you so much. Hi, everyone. Thank you for having me. My name is Kat Kruger. I'm an emergency nurse practitioner and I'm a researcher at University of Michigan. And my research really focuses on understanding how the global nursing workforce can and should be utilized as a key climate adaptation strategy. Thanks for having me.
Next, I welcome Dr. Sue Bell, who's a nurse scientist and family nurse practitioner whose work focuses on strengthening health systems and community resilience in the face of disasters and climate-related health risks. Dr. Bell.
Hi, thank you so much for having me. I'm a professor at the University of Michigan of nursing, and my nursing background is as an emergency nurse and nurse practitioner. I also am a member of a federal disaster response team where I respond to disasters across the United States. And it's really, my research really came out of working in disrupted communities and working in disaster response, where I wanted to try to translate the challenges I was seeing on the ground into research and policy-driven solutions. So that's what I do on a day-to-day basis now. Thanks for having me.
Thanks, Dr. Bell. Next, we welcome Dr. Connie Center, Chief Representative to the United Nations for the League of Women Voters of the United States. Her expertise span transcultural nursing, school health, sustainable development, and healthy aging across the lifespan. Dr. Center? Is Connie on?
Connie, you're muted.
Sorry. Good morning, everybody, and thank you for inviting me to be part of this. I feel like you're my extended family at this point because we've had connections for so long, and I'm going to emphasize some of that later. But I guess my background, Gil has already talked about, but one of the things, I'm just going to bring it down to a very basic level. When I talk to nurses and I say, get out of your comfort zone, but truly, if you are taking care of someone where the environment or the climate has made them sick and they're in your ICU and you treat them and you send them back to that same community or environment that has made them sick, what have you done, really? So this is why nurses should care. You need to be able to advocate in your communities. You need to be able to raise awareness. And that's down to the very basic level of thinking globally and acting locally. So over back to you, Gil. Thank you.
Thanks, Connie. And last from our panel, but certainly not least, is Linda Coe. She's an assistant professor at the University of Massachusetts at Amherst, at the College of Nursing. Her research focuses on sustainable plant-based nutrition interventions for health promotion and chronic disease prevention through community-based teaching kitchens and farm-to-school programs. Linda, you want to come in and introduce yourself as well?
Hello, everyone. Thank you for the opportunity to be here. It's nice to see all of you. My name is Linda Coe. I'm an assistant professor in the College of Nursing here at UMass Amherst. Thank you so much for the opportunity to be here.
Thanks, Linda. And our first question today will actually be for you. So we are curious what were your expectations going in, and how did the actual experience at COP compare to your expectations? We're curious about what is one myth about COP that you would want nurses to stop believing.
So thank you for the question. Going into COP, I wasn't really sure what to expect. I had first heard about COP back in 2009 when I was doing an internship in Copenhagen, Denmark. It was focused on development and relief and public health. And so I had heard that there was this opportunity to possibly go, so I was looking forward to it, but unfortunately I wasn't able to make it. So it was kind of in the back of my mind, and I ended up joining a group through the American Nurses Association Innovation Advisory Committee, and it was focused on planetary and global health. And so that's where I met Casey Belgard and Millie. And so they shared their experiences about how they had gone to COP in Egypt and also Azerbaijan. And I thought it was just fascinating that nurses could be involved at COP in this way. And so I was thinking, how could I get involved? Like, what could I do? And so I started looking through some of the things that were coming across from the Alliance of Nurses for Healthy Environments, and I heard from Kara about the opportunity to possibly go to Brazil. And so I was always fascinated by the Amazon rainforest. And so I was like, oh, this would be my opportunity maybe to get involved and go to COP. So I didn't really know what to expect. And so when I got there, I was looking to see like what ways I could get involved or what was out there for nurses that were just starting out. And so that was my initial interaction with COP. In terms of maybe like preconceived ideas or myths that I had going in, I think I thought that the people that went to COP were mostly like in leadership positions in government, like delegates, government officials, world leaders, and I didn't really see a way that a nurse could get involved, especially being at that point back in 2009, I was still doing direct patient care. So I think now that I've moved into academia, it's been really exciting to see the things that I learned at COP and being able to take those ideas and share them with the students that I interact with on a daily basis, as well as in the community. So thank you for the question.
Thanks, Linda. I think a sentiment you said there that's going to relate to a lot of people on this call is that idea of what can I do and how can I go get involved. And I'm so glad that you shared that was from your direct patient care experience as well, because that's the stage of our career where we're seeing the issues the most, but can feel the most helpless. But I think there are so many ways that we can find something to do, and I applaud you for going out there and finding it. It's so impressive. My next question is going to be for Kat. So Kat, how does in-person participation at COP strengthen advocacy, partnerships, and visibility for the nursing profession? And how does that translate into tangible outcomes? And if you have a specific example, we'd love for you to share it.
Yeah, thank you so much. That's a great question. So in-person participation at COP matters, but presence alone is really not enough. We really need to have strategic presence to really implement change in what's possible for the nursing profession. So we know that nurses are the largest health workforce in the world, and yet we're often underrepresented in these spaces. But by being physically present at COP, we can bring frontline credibility, live knowledge of community health impacts, and really the workforce perspective that policymakers often overlook. And we know that nurses will be the actors who primarily implement these policies related to climate and health, so we really must be helping to shape them. But presence without strategy or even intentionality can be really exhausting and ineffective. COP is overwhelming. There's thousands of events and meetings and conversations happening simultaneously. And what can turn presence into impact is really this intentional engagement. And it's actually something I've been talking about with my daughters a lot, and I think it also really applies here, is to really be big and to take up space. And so really the first step, I think, is simply recognizing our value in this space. Nurses belong here. We are experts. And so being present at these high-level events and using strategic networking can become a form of policy leverage. So for example, some tangible outcomes for me came from really small moments. For me, engagement with COP really included presentations with both nursing and non-nursing organizations. And in the moment, it can be hard to know whether or not these relationships can be lasting. And fortunately for me, they have been lasting. My experience at COP increased my involvement with both Annie and Sanciel. I'm now on the UN committee for Sanciel, and I continue to collaborate with Annie. And of course, I'm participating in fabulous events like this. And these moments and collaborations really accumulate over time. They strengthen the visibility of nursing as a policy actor rather than just a clinical workforce. And also, COP really helps validate your work. For me, before I participated in COP, I was part of a disaster research kind of networking group. And my initial impression was that they were kind of bewildered at why a nurse studies disasters and climate change. But after COP, the discussion shifted. And my presence at COP really validated my work, and now I'm doing a lot of research collaborations with them. And so finally, I'd like to share one more thing. Earlier this week, I was interviewing a global nurse leader for a research study, and she highlighted something really wonderful. She said that we often, as nurses, complain or lament that we don't have a seat at the table, and we can be guilty of waiting our turn or waiting for an invitation. But we are the right profession to be deeply engaged in this space. Nurses think in and navigate in complex systems daily. We're the most broadly distributed health profession, and so we know how climate change directly and indirectly affects health. So if I can share my big takeaway from COP, it's really that we should all be big and we should take up space. We belong here, and I encourage you to show up and communicate your value. Thank you.
Thank you so much, Kat. That was amazing. I completely agree that nurses need to be big, and I think the way we have even 3 organizations coming together on this call today, we can show how we are able to strengthen each other's platforms and make sure that nursing voice is big and united. That's exactly what we need to be doing in these global spaces. My next question is for Dr. Bell. Dr. Bell, nurses may not always see themselves as policy actors. How do you use your specific expertise, whether it's at the bedside or in your case as well in academia, public health, or administration, to influence climate action? And what is one sentence that nurses can use to connect their daily work to climate action?
Thanks for that question. So I want to flip the script and say that instead of nurses may not always see themselves as policy actors, ask the question instead, how can we help nurses see that they are already policy actors? And I think one way we can do that is through professional organizations like Annie, like Sanziel, and like ICN. And I think through that participation in nursing advocacy organizations, we can help nurses to see what their power is or what their individual superpower is. And that might be being at the bedside, holding someone's hand through the worst possible time of their life. It could be at the hospital level, setting policy and setting new protocols that are addressing environmental and climate action. And it could be taking on a major leadership role with an organization where you're actually sitting at the table at COP, participating in the negotiations. I think there's space there for nurses at all levels to act there. And every single one of the things I've outlined is equally important. And I hope that like through this example, we also see that nursing is this complex system that we can work together, where we can value those nurses that are at the bedside and those nurses that are doing the negotiations at COPs. And I wanted to give myself as an example in my own work. My main focus is as a researcher, and I do research that I hope leads to policy change. So I focus on disruptions to health and healthcare, from disasters, pandemics, and infrastructure failure. As I already said, I also am on the ground in disaster response. And what I see, some of the biggest impacts to health are from that disruption are around continuity of care and addressing chronic conditions. People just want access to healthcare and to have their healthcare needs met. And so that on the ground experience helps me to think about research questions and turn those into research projects that I hope will turn into policy change. And that's how I view what my contribution is. Thank you so much for having me. And I also wanted to say thank you so much to Annie for the encouragement to come to a COP and hosting me there and helping me along while I was there.
Yes, we all wouldn't have been able to do it without Annie guiding us, for sure. You just hit on how nursing has so many different layers in which we address our issues. It goes back to that ecological model that we all learned in undergraduate nursing studies. But whoever is on this call, you all interact at one of these different levels of nursing, or you're a nursing ally who's supporting nurses to do that. So Dr. Bell really touched how wherever we are, whatever role we're in, we have a part to play in climate action. My next question, I can open it up to whoever would like to take it. For nurses interested in global policy engagement, how can professional organizations and advocacy networks serve as an entry point into spaces like COP? And what did being part of a larger community enable you to do that you might not have been able to do alone?
I'm happy to take that question.
Millie.
Hi, everyone. So, you know, getting into global policy spaces like COP can really feel, as my colleague said, intimidating at first. And where do you really start, even as a nurse? And remember, I mentioned that my background was about 30 years of a mainstream oncology nursing as a nurse practitioner. So this is a world away from where I started. And that's really where professional organizations and advocacy networks make such a big difference in helping, clinically based nurses transition. They really act as your entry point. So these groups, such as Annie, such as Sonciel, and others, already have relationships, credibility, and access to spaces that would really be hard to navigate by oneself. I know it was hard for me. So instead of trying to figure out everything on your own, you're now making that choice to step into a community that's already engaged, whether that's through official delegations, side events, or policy discussions. And I think that it's even more powerful. What's even more powerful is what being part of a larger community actually enables you to do. So for me, it wasn't that I was just showing up as one individual voice. I was part of a collective. And that gives your message, my message, more weight. It opens doors in collaboration, mentorship, and real-time learning from people who've been in these spaces before. It also helps to create opportunities you might not have access to otherwise, like speaking on panels, contributing to policy statements, or really just being in the room for critical conversations. Alone, that can be really hard to achieve. And my last thought on this is, together as a network, you're not only amplifying your own voice, you're helping to elevate the role of nursing in global climate and health policy overall. And that's really our goal, right? Making sure nurses are seen, heard, and actively shaping these decisions. Thank you.
Thanks, Millie. Yeah, we couldn't agree more at the International Council of Nurses, being a professional organization ourselves. And it's so great to have so many other ones on the call today. You really can stand on the shoulder of giants when we all team together. I know my organization is from the 1800s even, founded by women's suffragettes. So we're standing on all of those nurses that came before us and standing with all the other nurses advocating today when we interact in those professional organizations. My next question will be for Dr. Sensor. How was attending COP concretely changed how you practice, teach, research, or lead? What is one change, however small, that you implemented after returning? Connie, you're on mute again.
Thank you for the question. I just wanted to emphasize how important it was what Millie said, what Milena said, what Nanny said about us all coming together, right? And I use my relationships with professional organizations like ICN, like Sunciel, like Annie, to gain information in a collective way and fact-checked information that makes it easier to have those discussions and to use those examples. I think there was one kind of paragraph that put it together in terms of storytelling and to emphasize with students and with the public just that storytelling is such an important part of this. So I just wanted to share that piece, that think of how powerful this one paragraph is. And if you could use it over and over again in different ways to connect it to a story in a personal way. But pregnant women exposed to fossil fuel pollution, this is how fossil fuels damage human health at every stage of their life cycle, right? So pregnant women exposed to fossil fuel pollution face higher risks of preterm birth, low birth weight, and congenital abnormalities. Children exposed to air polluted by fossil fuels suffer more asthma, respiratory infections, and developmental harms. Adults face increased rates of cardiovascular disease, respiratory disease, cancers, kidney and liver damage, and neurological conditions. And even after extraction sites and refineries close, their toxic legacy continues to poison air, soil, and water for decades. And all of these cumulative diseases then put increased stress on the workforce. So I think that when you can emphasize any of these in your curriculum and say, just this one sentence, weave it in. How does climate and environment affect human health? And this is an essential takeaway from COP. But the best part is that what everyone has emphasized, our collective presence amplifies our voice, makes us stronger. And I would always encourage people to belong to professional organizations or networks, and then take it one step further and think about policy and how you can influence policy with your vote. So I think voting is how the League of Women Voters ties into all of this. Vote for policies that promote health and protect our planet.
Thanks, Connie. And that segues really well into a question I'll ask all of the panelists, which is, what is your biggest piece of advice for nurses who want to have an impact on the global level in climate action, since it's what we're talking about today, but also we're here for CSW, and this is a CSW event. So in gender equity and all of those other elements that intersect with both health and climate as well. I invite our audience members, you can start posting your questions in the chat, because after this response from all of our panelists, we'll go to questions from the audience. One more time, that was, what is your advice for people who want to make an impact at a global level? We'll go back to the top and start with Linda.
Thank you. I would say, going back to what Sue Ann said, looking to join an organization and getting involved that way. You can find all different activities. And then the second thing I would mention is to look at where you are currently situated and how you can get involved, maybe in a way that you haven't necessarily thought of before. I know a lot of times as nurses, we do different tasks, but we don't always think of the impact. And so when I was doing my postdoc, I was working with a farm-to-table camp for school-age children from kindergarten up to 8th grade. And I was thinking, what are the ways I could maybe teach kids about sustainable food systems or about plant-based nutrition and the way it impacts health and also can be beneficial for global health as well. And so I created, with a team and a graphic designer, we created a book, a children's activity book, and based out of that book, we've now received funding to translate it into 10 languages. We've created a quick guide for use in the clinical setting, and we're just finishing up a guide for teachers and parents that are wanting to use the book at home or in school settings. So just starting small and looking for ways to maybe expand from there. Thank you.
Thanks, Linda. And I believe we had Kat next. Stick with the same order.
Yeah, I'll keep mine very kind of short and simple. I would say if you're waiting for an invitation to get involved in this space or lead here, this is your open invitation. Inject yourself into this work, and if you want to do it individually or you want to join the organizations who are already working in this space, just jump right in.
Amazing. And Dr. Bell?
I'm going to capitalize on what Kat said. Just to add on to that is to find, what really drives you. What are the issues that you see around climate and climate action that, stir you to action, or that have affected you personally, or that you want to invest your time in, and start there. I think looking at it as a whole can be overwhelming, but starting with, those small steps that you can take and build into something larger can help you feel like you're actually doing something and help you take action.
Thank you. And next we had Millie.
Yes, I'm actually going to bounce off of and echo what Dr. Bell said about it can be overwhelming, this space, and really honing in on your area of interest as a starting point. For me, two areas of interest, as using myself as an example, was really gender equity. Women are the most impacted in climate disaster events. We are 80% of migrants due to climate disasters are women. And who do women travel with? Well, we travel with our babies. So that's a very vulnerable group. And also another vulnerable group that has always been my interest is disabled, those in the disabilities groups. So how does this really manifest itself in those particular populations? For me, that was a key that opened the door to everything else. So I invite you to really look at what matters to you and how that fits in. Thank you.
Thank you. And last but certainly not least, Dr. Sensor.
Yeah, I just wanted to emphasize that, COP is a culmination of bringing people together, but the work continues year round, right? So there are places to look for consultations. UN Web TV has archived briefings related to climate. My first COP, I went to every event Climate Week in New York in September to just meet people and to learn, where there were connections and where there were spaces. But then those opportunities start to open up. And so if you're looking on a regular basis through things that are happening at the UN, you can see where there are opportunities for consultations or to belong to committees where you have input all year long. And then your expertise starts to become more recognized, and you get to be a spokesperson, you get to be invited into more spaces. So I would say look for those opportunities within committees way ahead of COP. The preparation for the next COP starts when COP 30 ends. We're preparing already for COP 31 and looking at, the what next part and where we feel that we need to put more emphasis. So like Millie said, focus on one or two areas. There's so much to climate, but if you're looking at gender issues, if you're looking at health, narrow it down and then narrow down your 30-second soundbite about your scientific expertise. And we all have the ability to do that, but we can all mentor and coach one another in ways to do that better.
Yes, we all have to stay proactive as a profession and not just reactive. And that's probably some of the hardest parts of doing policy work. So I'll take our first question from the chat. Amanda Doe asks, what does it mean for a country to not be listed in the Bellum Action Plan? So I'll start answering this, but then I'll turn it into a question for our panelists. So at many different UN events and at many different ways that we engage at that global level, governments are making commitments to follow different resolutions. And these commitments are often not held accountable by any sort of legal mechanisms or anything under those lines. So the countries that signed on are those ones that stepped up and said, we are making a commitment to that. However, we know from the Paris Agreement and many other UN agreements that doesn't always mean that countries follow through on the commitments that they made. So maybe what I'll ask for our panelists is how can we all engage with our home countries' governments to educate them about what this Bellum Action Plan is and make sure that what is happening globally is known and acted on locally. I'll open that up to any panelist who's interested.
I can just quickly give my perspective. To your point, Gil, acting locally while thinking globally is powerful. And so I would say that in this current administration, the Fed looking to the federal isn't necessarily, it's more of a barrier than looking to our local policymakers. And so what that would look like is maybe your governors maybe your mayors or even your council people, because effective change can look as clear and as tangible as asking your town to invest in things like solar panels, and being able to explain as a nursing professional the importance of renewable energy, and even higher than that at the governors. Why is it important for governors to participate in COP? Because there was a segment of governors, believe it or not, that did go to COP. So do you want your governor to participate? And what demands or requests do you have for them? So I'll leave it at that. Thank you.
Thanks. Would anyone else like to comment on how to get global action to be implemented locally? Go for it.
I would just go back to a theme that we've talked about throughout this talk, and that is voting, using your voice through voting, using your voice through supporting candidates that have climate action on their agenda, and voting for those candidates and supporting those candidates. I heard Millie talk about governors. I saw the governor of California, Gavin Newsom, at COP30 in Brazil. And, to me, I don't live in California, but seeing that representation and knowing that that's high on California's agenda was, very inspiring to me to see in action.
Would any other panelists like to comment on that as well? Otherwise, I'll go to the next question.
Well, no, I just wanted to say, not to turn this into a USA-centric conversation, right? But Senator Whitehouse from Rhode Island was the only U.S. presence from a high-level government perspective, and he came with the same badges that we had as observers, because the U.S. was not present at COP. And he said, our president has a fossil fuel agenda, but Americans have a climate crisis action agenda. And so we're still very much engaged in this. So I agree with the other two speakers who said, yes, let's talk to our governors, let's talk to our local politicians, because we do have space there to influence. And if you don't have health, what else matters, right? So say that all the time, like health is a universal that unites us, because we all want to have health and be as healthy as we can be. So huge emphasis on that. And our nursing cap, always identify yourself as a nurse in the conversation, make yourself visible, and let people know that nurses have the capacity and agency to contribute to these high-level discussions, because we do. And that beacon, trust me, and and listen to what I have to say.
That's so right, Connie. And Gil, I don't want to just step in here, but I'm seeing so much great engagement in the chat. And I want to open up an opportunity for some of those who are asking these questions to have direct contact with some of our panelists today. So maybe we can go into some breakout sessions for about 10 minutes, and you can ask some of these questions directly and really engage with some of our amazing nurses. I want to invite you, we're going to have 3 different breakout rooms that you can choose to go into. Number 1, we'll do getting started in healthcare advocacy. If you're just starting out, please join Millie and Linda in that breakout room. If you want to know more about that local to global, global to local, and implementation of solutions, you can join Kat and Dr. Sue M. Bell. And then if you want to get more specific, asking some questions about the participation in the UN negotiations, you can follow Connie and Kara there. I'll stay here in this main room, and I'll also be moderating the chat.
And just a technical, for those who aren't seeing it, you should see an option to click on breakout rooms on your Zoom screen on the bottom tab. Once you click on that, you will see the 3 rooms, and you can move yourself in that way. If anyone is having trouble, just let me know. Just say right now what room you want to go in, and I can pop you in there. Or you can also